We have Mandarin.
你们好，欢迎你们上我们的 Sacramento 的这个沙加缅度的有关这个冠状病毒的这个疫苗的讲座请你们在下面的这个地球仪上面选项这个中文翻译，那进入到小房间，我们等一下会为您做同步的翻译。如果你们有任何的问题想要提出来的话，欢迎你们放在这个左边的这个 Q&A 的这个专栏上面，这样子等一下呢这个主持人会挑选一些问题，然后来为您做这个解答。谢谢您。
Thank you. And last but not least, we have Arabic.
مساء الخير. أنا اسمي أحمد مخيمر، أنا مترجم ملخص لي من المحكمة، وأقوم اليوم بترجمة كل شيء إن شاء الله لكم. الأول حيعطي المسؤولين عن الإدلاء بالتقارير لكم تقرير كامل عن موضوع المرض الوبائي، وبعد كده هيشرحوا لكم كل شيء وكل شيء واضح، وهنحاول نترجم لكم كل شيء بدقة. وبعد كده هتقوموا حضرتكم بتقديم أي أسئلة أو استفسارات للجنة، وأنا هنقوم بقراءتها وترجمتها الإجابة إن شاء الله. نرجو لكم حظ سعيد وفرصة سعيدة إن شاء الله. سلام. Yes, thank you, Mark.
Thank you. And with that said, now our interpreters are each going to be assigned to their room. Interpreters, if you could accept the invite and unmute when you are in your room. And as a gentle reminder, the interpretation is on the global function, and you could join the rooms to utilize interpretation services for tonight's event. If everyone can please, again, utilize the Q&A chat box to ask your questions there, and we will do our best to answer as many questions as possible. So with that said, again, welcome back to our community COVID-19 community forum. I have the honor to introduce our lovely guest speaker, Dr. Cohen, today, along with our public health officer, Dr. Kasirye, and my amazing colleague, Rachel. So with that said, I will pass it on to Dr. Kasirye to do our update. And please turn on your cameras, wonderful wonderful speakers.
Thank you, Mike. Good evening, everyone. Just to give you a very brief update of where we're at with the numbers, we are at 91,393 cases of COVID-19 that have been reported to the county. We are averaging about 222 cases per day, so this has dropped a lot. If you recall, in December, we were at the point where we were getting 1,000 cases a day. So we have passed the peak, and we're continuing, the numbers continuing to decline steadily. The average cases is 14.2 per 100,000. And the deaths, we have a total of 1,412. Looking at the blueprint for reopening, which is the state website that shows our progress and the tiers, we are still in the purple tier, which is the most restrictive. And according to the last update for the blueprint, we are at 18.7 per 100,000 cases. Often we are asked why our number is different from what is given for the state. And the explanation is that the state numbers have a 7-day lag. And so the numbers that we provide here, we update them on a daily basis. And so it gives you an idea of where we're heading, and it helps for planning. With the state website and the blueprint, the number is what is used for determining what tier we're in. So both numbers are important, and both of them are accurate. They're based on data, but they're based on a different time frame. And then for test positivity, we're at 6%. In order for us to get to the red tier, our test positivity has to be below 8%. So we're at that point, but our case rate also needs to drop below 7 per 100,000. So we still have a little way to go. We are thinking that based on the rate at which the case count is dropping, that we will be able to get to the red tier sometime in the next month in March, but we will definitely keep you updated on that. So with that, I am going to turn it over to Dr. Cohen to talk to us a little bit about the clinical side, and then we'll go to Rachel and then questions.
So, hi, everybody. Welcome again to this forum. I can speak, since I work at UC Davis, I can speak for us. Our rates have gone down significantly, and the number of patients that we have in the hospital has been cut in a third over the last 3 or 4 weeks. And there are still a handful of patients being enrolled or brought into the hospital, but it's quite limited. I mean, we had periods of time where there were over 100 patients in the hospital with COVID, and now we're down in the around 30, and we are maybe admitting 1 or 2 new patients a day. And so, and a lot of the patients that are in the hospital are people who've been very sick and stay for a really long period of time. So we're seeing this significant decline in patients, and also our healthcare worker vaccine rates are pretty high, and we're seeing a lot less of our healthcare workers getting infected now too. There are still some, but that will be hopefully part of this discussion tonight. Thank you. Do I pass it on to the next person? Is
Sure,
that
I
the
can
trick
go.
that I missed? Sorry. So Rachel, you're up. You could introduce yourself.
Okay, yeah, thanks for having me back. I'm Rachel Allen. I'm the immunization coordinator for Sacramento County Public Health. So I'm happy to be back again and hope to be able to help answer some questions. Just to update you where we're at, we're still receiving our vaccine allocations on a weekly basis. So we do just find out once a week how much vaccine we're going to have, and it is still fluctuating. So it's a little bit different every week. This is great. You can see this is the document that we use on our website to show you who we're vaccinating. So still working on phase 1A, of course, and will be as we continue. But if you scroll down a little bit, we've moved into phase 1B. And I think the last time we talked, we were doing 65 and over, and we had started law enforcement and emergency services. But this week we did open up vaccinations to childcare and education. So that's a big change this week. Another big group of people that have been waiting, I know, to get vaccinated. And so, you know, still going to take time to get to everyone, but we've started opening up appointments and starting to see some of them be able to be vaccinated. This week we did have an extra challenge, and you may have seen in the news that the weather, the storms that the US has been experiencing did impact vaccine shipments, and most of our providers are letting us know that they're running pretty low, as are we. Very challenging, but not a lot we can do about it. So, you know, when we are starting to see some providers need to cancel appointments, but we're hoping to get those vaccines. I'm hoping tomorrow. Every day I hope it's coming. If not tomorrow, it won't be until Monday. So just another bump in the road, but we'll get past it. And so we are continuing to operate our site out at Cal Expo, and just about up to the capacity that we thought was a goal that we had, which is 1,200 patients a day. And it's going well. Again, we have to have vaccine to keep it rolling, but things are going great there. We're also still developing further partnerships, working with medical practices, clinics, pharmacies, and then of course we have the partnerships with some sites that are able to do larger throughput. So Cal North State and Sac State have been awesome partners. And I want to say too that the volunteer, we have a wonderful volunteer force. So just giving them a little shout out that we're really grateful for all the volunteers that come day in and day out, doctors and nurses and other medical and non-medical volunteers that help us. And I think that that's it. Oh, we are in the process of onboarding to My Turn. So you may have heard something about that in the news as well, and even visited the My Turn website. And that's a website that California has developed where a patient can go on the website and put in their age or their work type and see if they're eligible for a vaccine. And if they are, it can help link them up to finding an appointment. So there's two sides of My Turn. There's a side that the public will be able to use, and then there's a clinic side. And so Sacramento County is in the process of onboarding to that so that we will be a part of that as well. Eventually, we're not onboarded yet, but hope to be in the near future. I think that's it.
Thank you. And with that said, we'll dive right into our questions for the night. Again, gentle reminder, community members, if you all would like to participate, please utilize that Q&A function to ask your questions. So the first question, at what point will we finally be able to stop wearing masks?
I think the short answer to that is that we're still a long ways off. We still need to get through vaccinating. Our numbers still need to drop. We're hoping that by the summertime, we will have vaccinated enough people to reach herd immunity, but that will depend on how much vaccine we're getting. And we'll definitely continue to monitor. It's very important that we continue using our masks right now, because we still have, even though the rates are dropping, we still have quite a lot of infection and transmission in the community. And so we want to make sure we continue to protect our loved ones.
Our next question is, the communities hit hardest by COVID-19 are the poorest in our country, our county, like Del Paso Heights and South Sacramento neighborhoods. How is Public Health Department going to ensure that COVID-19 testing and vaccination sites are both equally accessible to all demographics and communities in Sacramento?
I'll start off, but I would like both Rachel and Dr. Cohen to say something as well. So one thing that's important that we want everyone to know, we know that the state did publish some numbers recently that indicated that communities of color are not getting as much access to the vaccine as the white population. But I think it's important to recognize that that is because of the tier structure that we are working with for the prioritization. We started off with people, especially the occupation sectors. We started off with people in healthcare, and then went to law enforcement, and now to education. I think that the disparity that we're seeing with the vaccination is because of the disparity that exists with these occupations where there's an underrepresentation of minority groups. We are very aware of the work that we have to do in being able to reach disadvantaged communities, making sure that we're able to work with trusted voices within those communities, community leaders, being able to work with community-based agencies that are already providing services in those communities, and also being able to address some of the vaccine hesitancy. We're aware that for many of these disadvantaged groups, there's a certain level of mistrust of the medical establishment. And so we need to work to be able to make sure that we address the questions that we have, and we give them a level of confidence that is needed, that this vaccine is safe, and that we will do everything to make sure that we make the vaccine available to all the communities, including addressing some of the barriers. And that will include things like being able to have sites within the communities to address people who don't have access to transportation, being able to work with partners like SAC-RT to provide transportation to some of these clinics. And for the disabled, looking at different ways of being able to provide services either through their own healthcare provider, or for those that are bedbound or homebound, to be able to have strike teams that will actually be able to go to these homes and provide the vaccination. So I'll hand it over to maybe Rachel first, and then Dr. Cohen, if you'd like to add.
Sure. Yeah, I would just echo all of that. And so my team, which is consists largely of nurses, are working really hard on this project. And we do know that we can't, that these large sites in some locations aren't going to work for everyone in the community. And so we are actively working on this. We have teams that will be able to go out and do clinics out in the community. We're putting together the materials that we need to really assess sites and make sure that they're prepared. And I think I've talked about this on calls before. It's not quite like doing a flu clinic. We're really good at going out and doing flu clinics, but this takes a little bit more consideration and thought. But we do want to make sure that we have equitable access, and it is a priority. So I would say that we aren't going to forget about this. It's very important. We're still pretty early in this, and so it's been a lot to just get this response off the ground. But this is extremely important to us, and I would say something that we are working on every single day. And of course, one of the biggest things that needs to happen is some more vaccine as well. So when hopefully when vaccine is flowing a little bit better, we'll have these plans in place and be able to reach these communities and bring the services where they're needed desperately.
Yeah, and I support everything that you guys have said. Just prior to being on this call, I am on a committee, an ethics committee that's University of California wide, talking about these very issues. And one of the things beyond just disadvantaged populations is that the registration to get these vaccines is on computers. And so people who don't have computer access, who can't use computers, often the tier 1A people, right? The people who are over 75 are people who don't really have that kind of access. And so it's tricky to be able to get all this out, and I appreciate the effort that Sac County is putting into this. We're doing the same thing at UC Davis, and I suspect all the other health systems are likewise doing the same thing. We want to make sure that we get people vaccinated who are at the highest risk the earliest on in the pandemic. And so I think it's tricky. And once we have a lot of vaccine, which seems like it may be coming in several months, then it's going to be trying to talk people into vaccines who are hesitant and are distrustful of the vaccines and the health system. Right now, I think in a period of scarcity, that seems to be less of an issue right at this particular moment, because there are a lot of people who want vaccine that can't get it. And I'll leave it at that. Thank you.
Thank you. And just a gentle reminder that we will do our best to answer as many questions as possible. If you hear your question asked in a different way, it's just because we're collecting and trying to gather and consolidate as many questions that have the same theme. So with that said, the next question is, does the vaccine interfere with someone that's currently on medication, or medications interfere with the vaccine?
So I can take that. So we don't have any medications that will be interfered with by the vaccine. So I think that's easy. The vaccine is separate. It generates an immune response. It's cleared from the body relatively quickly, and so it doesn't interact with any medications. Now, as far as medications potentially playing a role in the vaccine, it doesn't preclude anybody from getting the vaccine. So regardless of what medications you're on, you can still receive the vaccine. The issue is that with some patient populations, the vaccine may not be quite as effective because any medications that may lower your immune response or lower white blood cell counts or something else might actually be associated with a lower response to the vaccine. People who were significantly immunosuppressed, so whose immune systems were markedly down, were excluded from all these vaccine trials. And we know it's safe in those groups, but we don't know how well it works. And so we're still going to be vaccinating. That's still a very high risk group to be vaccinated. But it may not work quite as well, and we'll just have to see as the data roll out.
I'm just wondering if, Rachel, if you want to say something also about other vaccinations. I know that's a question that we've been asked sometimes, that can someone get the COVID vaccine at the same time as other vaccinations?
Yeah, I think, and Dr. Cohen, you can correct me if I'm wrong. I think the guidance is to put 14 days. I'd have to go back and look. I think it's 14 days between vaccinations.
Right. You're right.
Okay, yeah, mainly because we just don't have, again, it's a new vaccine. So we want to make sure that we've got some time under our belt before we can co-administer it. And probably, I mean, I think down the road, I hope that we can, we normally do. We try to utilize opportunity when patients come in and make sure that they have all their vaccines that are due. So, but right now we're administering it by itself within 14 days before or after other vaccinations.
I just point out again that the all the studies were done exactly like that. So you couldn't have a vaccine within 2 weeks. And so that's what we know right now. And until, right, and even the vaccines that are co-administered, so when the kids get a bunch of vaccines all at once, those are all studied to demonstrate that there's no interaction between them, and that they all work effectively. So this will require a lot more work. And I think at this point, the goal is to get the pandemic under control, and the other stuff can be worked out later.
Thank you. And the next question is, I have heard more people getting reaction as a result of COVID vaccines with the Moderna vaccine. Why is that? What are the differences between the Moderna and Pfizer vaccine?
So there are a couple quick points, because I also saw something in the chat asking about why more people are getting the Moderna vaccine than the Pfizer vaccine. So, so first off, they both work exactly the same way. The guts of the vaccine are pretty much the same. It's the outer coating of the vaccine that's slightly different between the two of them. That said, Pfizer vaccine has to be stored at very low temperatures, minus 70 or 80 degrees centigrade, which is an ultra low freezer, as opposed to the Moderna vaccine, which could be stored in a freezer similar to what you use at home, which is minus 20 degrees centigrade. And so that, so the Moderna vaccine is automatically going to be more accessible to places that don't have this ultra low cold storage system. And so a lot of the pharmacies, that's what they have, is the Moderna vaccine when they're giving it out, because it's easier for them to manage and store, and they can store large amounts, whereas larger health systems have these minus 70 degree freezers and can do more Pfizer vaccinations. I think that, for example, we've done an awful lot of Pfizer vaccine compared to Moderna, but I think that's not the case in other circumstances. And I think that when you look at actually the studies, the number of side effects are really not different between the two vaccines. They're almost exactly the same. I think that maybe it's an artifact of more people getting the Moderna vaccine that you hear about more side effects associated with the Moderna vaccine. But the numbers are actually lower now that it's being rolled out to the general population than what was seen in the studies. And so I think, and we always tell people, it's just your body generating an immune response. Fever or feeling crummy for a day or two probably tells you that the vaccine is starting to kick in, and you should probably smile about it, even though you don't want to feel that way.
I also want to take the opportunity, thank you for that explanation, to again differentiate between adverse effects and side effects. Side effects, as Dr. Cohen has mentioned, happen more frequently, especially with the second dose. So actually, when you're going to get your vaccination, they will tell you to expect that you might have some of these side effects, as he's mentioned. It might be tiredness, low-grade fever, or a slight headache. And they last just 1 or 2 days. And that's because your body is mounting a response. But the adverse effects are much more severe and they're much rarer also. And that is why when you sign up for your appointment, you will be asked questions such as, have you ever had a bad allergic reaction to a vaccination, or do you have to use an EpiPen for any reason? And also after you get your vaccination, you will be monitored for 15 minutes to make sure that you're okay, or 30 minutes if you have a history of severe allergic reactions. So those are much rarer and much more severe, but it's very difficult, very important that people are able to distinguish the difference between the two.
A community member says, I'm eligible for a vaccine, but due to personal reasons, cannot get a follow-up for about 5 weeks. What do you recommend?
So all the recommendations right now are to hit the targets that the clinical trials had, which was 21 days after the first dose for the Pfizer vaccine and 28 days after the first dose for the Moderna vaccine. CDC has said it can go out to 42 days, which is 6 weeks, which is beyond the 5 weeks that you can't reschedule. But there actually are some studies with the AstraZeneca vaccine, which is not yet approved, that suggests that actually a longer period of time between the first and second dose generates a better booster response. So the general rules are 6 weeks as the outer limit. I'm not even sure that I totally believe that, but that's how we sort of have to work right now. So I don't think it should impact you getting vaccine if you can't follow up for 5 weeks.
There are a few questions about different mutated strains and variants. Have there been any mutated strains found in our state or county? And what is the plan for these variant strains?
So the answer is yes. So first off, we know within the state of California that the so-called B117, which is the British variant, is everywhere in the state. there's also a second strain. Actually, there are two other strains that are being sort of called the California strains that are seen primarily in Southern California. One of the people out on the Davis campus right now is doing some testing. So we do asymptomatic testing for our healthcare workers, and they do asymptomatic testing on the Davis campus for students and for community members. And we're actually hoping to expand to community members here in Sacramento as well. With that said, there are positives that pop up, and now in the laboratory, they're doing the testing to determine whether any of these are variants. And they're finding a handful of them, not a ton. I'd say 3 or 4 so far is what I've heard out of the positives. So I think it's circulating, and I would assume that they are. I don't think that the South African or the Brazilian variant has been seen in California yet, but I wouldn't be surprised that it is. I think the best strategy to address these variants are first the rollout of the vaccine happening as rapidly as possible, and that's going to be totally based on how much vaccine we have available. And then that's the other argument for using masks and maintaining all the so-called non-pharmacologic measures to control transmission. So 6 feet apart, not meeting in big groups, and washing your hands. There are some studies with 2 of the other vaccines, and I think where there were people enrolled in South Africa and there were people enrolled in Great Britain, where with the British strain, the vaccine efficacy or effectiveness seems to be maybe 10% less. The South African, it's significantly less. It's probably closer to 50%. And so, but it's still protective, right? I think that's the big thing. And it's still also suggestive that people don't get very sick. And so I think that's the important part of it. And I think that may be, by the way, when people are going to talk about the 1-dose Johnson & Johnson vaccine that will, I think, is finally going to go to the FDA in the next week or two. It looks like it may be a little bit less effective than the 2 vaccines that we're using now. But I should point out that the study was done later when some of these variants were around, and part of the study was done in South Africa. And so I think that we have to be cautious about saying one vaccine may not be as good as the other based solely on numbers, because things are different, right? We just finished enrolling a vaccine trial here last Thursday, and that's also going to be a different group of patients that have been enrolled over the course of the last 8 weeks or 6 weeks, as long as it took us to enroll it.
How certain are health officials that isolation for 10 days is sufficient, assuming symptoms has improved significantly? My friend was tested positive, so he isolated for 10 days. He did feel better, but went for another test and came out positive. Under this circumstance, is it safe for him to go back to work?
If no one else, you want to take it?
Yeah, I'll start off, but you can certainly add to it. Yes, the 10-day limit was established based on a lot of studies that were done, which showed that I think it was over 90% of people were no longer infectious after the 10-day period. And that is why we end the isolation at that time. But the test that we use, the PCR, is very sensitive because what it does is it detects particles of the RNA that are still within your system. So because of that, and also because some people do continue to shed virus for a long time, as long as 90 days in some situations. So that is why actually we do not recommend that people go back to get a second test after they've tested positive. So if you were to come to one of our sites and get a test and it's positive, we'd tell you to isolate for the 10 days, make sure that your symptoms have improved, and then you would be able to come out of isolation. You do not need to do a second test.
Yeah, I agree. We have actually a limit on our ordering, where if somebody were to come back to the hospital for another reason, and we're routinely testing people who are being admitted to the hospital, if they were tested in the last 90 days, they can't get tested unless somebody approves it. The only group where this is a little bit different are the severely immunosuppressed patients, because they probably do have live virus still out beyond 10 days. And so those groups do have to be retested and have to clear before isolation is over. But for the vast majority of the general population, you can't grow virus out of people after 10 days.
So I guess another community member asked, then are fully vaccinated individuals need to still follow guidelines such as wearing masks, social distancing, and not gathering?
Yeah, so this is a burning question, I must say, and I'll be interested to hear what the health department folks have to say as well. We've made the argument that to date, what we know is that the vaccine prevents disease. We are not 100% sure that it actually prevents infection. And we think that it probably does, because most other vaccines that we give prevent infection as well as disease. So the odds are that that's going to be the case. But until we know that for sure, it's still possible that people can be infected and be asymptomatic, so they can be infected but not have any symptoms. And then they can go back to their family and transmit it, or they can go into a grocery store or something like that if they weren't being masked. And there are multiple reports of people who don't respond to the vaccine. Again, all the vaccine effectiveness information that we have so far is that it's about 95% sensitive. That means 1 in 20 don't get a good response to the vaccine. So that's still a significant amount. And so until the number of people in the community are protected so that the virus is not really circulating at a high level, I think that we're stuck with masks.
If someone has the first vaccine, how does that affect COVID-19 testing?
So for if you're testing for virus, it shouldn't affect it. So when somebody does a nasopharyngeal swab, where they stick the swab up into the back of your nose, or they do a regular nasal swab up at the front of the nose, or even if there are some places where you can test saliva, the vaccine will not change that. If you're doing a blood test to see whether you've had COVID in the past, depending on what part of the COVID virus the antibody test is targeting, the vaccine may affect that result. But we don't really use those antibody tests very frequently. And so the routine test to identify COVID in somebody is not affected at all by the vaccine.
Another question is, what will the role of Blue Shield be in vaccine distribution? Are they working at a state level, or will they have a role at the county or clinical level?
At this point, we don't know. We are still in the process of learning how we will be able to work with Blue Shield.
A community member asked, can you explain the vaccine distribution on the various government levels?
I'll let Rachel take that one.
Sure. Yes, so there's a few different streams. The state does receive vaccine from the federal government, and some of that vaccine goes to the larger health systems, like Dr. Cohen was saying. The larger systems get their vaccine from the state, and many of them get Pfizer because that's something that they're more capable of carrying. But then the state also allocates vaccine to local health departments, and we then allocate again that to the providers within our community based on the priority groups that we're working with. And I think I might have seen this question. We do allocate to some pharmacies, and so it's a little confusing, but then now the federal government has started out, or is it the state, I think, has started allocating directly to CVS and Rite Aid. We're working with some other pharmacies as well. So pharmacies are a little bit of a mix still.
There is a question, and maybe this could be an opportunity to pull up the COVID-19 tier vaccination, because people are wondering, where are family caregivers on the vaccination chart, along with agricultural workers?
So we did, let's see, I need to make my little box go over here there. Go ahead and scroll so that we can see phase 1A. We did do in-home support service staff there. I'll have to ask you, Dr. Kasirye, about family caregivers. I'm not positive. And then we have not yet gotten to agriculture workers. We are in phase 1B. And if you scroll there, you can see that we're checking down the column there and just opened to education 2 days ago. So we do need a bit of time to work on that group before we're able to move to agriculture.
Does that also go for 1C? Because there's also a question is, when will 50 to 64-year-olds be eligible?
At this time, we don't know, because we are, after we get through the phase 1B tier 1, we are going to change to an age-based system. But at this time, I don't have a date as to when that is going to happen. And then to go back to the question that Rachel was answering about the caregivers, yes, they are included in phase 1A.
Community member states, it is very hard to get an online appointment. A person has to be very tech savvy. Is there a way to get an appointment easier, especially for older adults?
Rachel, you want to take that one?
Sure. Yeah, we're very aware that most of the options right now are still pretty tech dependent. And so especially for older people, having a phone line is a better option. And I know that there are some sites that already offer that. Some pharmacies do. At Public Health, we are still working on getting that fully up to speed, but do hope soon to have a phone system working that people can call into. I believe My Turn will also have that option where a person can call in. And I think now if someone really is eligible and they cannot access the vaccine, they can call Public Health, and we are willing to help.
Is it possible to be reinfected? I heard about re-positives.
I think that people can be reinfected. The immunity sometimes wanes, particularly people who had very mild disease. And so if they had disease a year ago and now get exposed again, their immune system may have already forgot about the virus and they may get infected again. It's very uncommon, but it has been reported. And so I think it's a consideration, and it may also end up being a little bit more of an important issue when and if the variants become more prevalent in the community, right? If it becomes like Great Britain, where the primary virus that's circulating around is one of the variants, there may be more people who get infected a second time.
Earlier, Dr. Cohen, you talked about disease and infection, the prevention of disease and infection as you were describing the COVID-19 vaccine. Can you further elaborate and explain what the difference between disease and infection?
Yes, I'm happy to do that. I'm sorry if some of my answers are not totally hitting what people are asking, but infection just means that the virus is in your body and growing. But people who have no symptoms are still infected. That's called asymptomatic infection. If you end up starting to have disease where you have cough and shortness of breath, and or you lose your taste and smell, those kinds of things, that's disease. So not every infection causes disease, because about half the people don't have symptoms, but everybody who has disease is infected. Okay, I hope that's a little bit clearer.
Thank you. What is Sacramento County Public Health Department's plan to improve the overall health of the poorest population so that comorbidities such as heart disease, diabetes, and obesity do not continue to be the greatest risk factors for COVID-19 outcome?
Wow, that's a great question. I think it's important to recognize the root causes of many of these diseases and be able to address those root causes. And I think it's also important to recognize that public health alone does not have the capacity nor the ability to deal with all of the factors that contribute to the disparities that we see. And that's one of the reasons why in public health, we work so hard to network with entities in the healthcare community, as well as entities in the community, and also working with those communities that are affected to address those issues. Some of them can be addressed by changing policies that do lead to some communities being disadvantaged and not having access to healthy food, where you have things like food deserts, or not having access to resources. But some of them also require changes in the system, such as being able to give more opportunities, for example, for education, for even disadvantaged communities. We mentioned at the beginning about the fact that part of the reason we're seeing the disparity with the vaccination rates by race ethnicity is because when you look at the occupations that we prioritized initially, healthcare, law enforcement, and education, there's an underrepresentation of minorities. And that would have to be addressed by working with the education system so that we give more opportunities to those disadvantaged communities to have those chances. And part of the reason that education is so important is that we've shown time and time again, as we look at socioeconomic factors, that there's a very tight correlation between health and socioeconomic factors, which includes education. So that's one way that we can work on it. So I think we often talk about it takes a village. And I think it does take a village to raise a healthy child who is successful. And so all of us need to be at the table with policies, with resources, with social support that will be able to help individuals be successful. And that will improve their health.
There's a mentioning of $60 million from the federal level coming down to the government, local government. Have there been any plans or discussion on how to utilize that funding? And some of the other participants along those lines also asked, does that include free vaccination to community members?
Right now, vaccinations are free to community members. The reason that we're not able to get to everybody is because we're getting a limited number of doses. But as soon as the supply increases, we are working to ramp up so that we can provide more vaccination clinics and more opportunities for vaccination. As far as the $60 million, we are still waiting for the state to give us details on the scope of work and what we can use that money for. But in general, we do have an idea that some of that will be used for public health infrastructure, but part of that will also be used to work with community-based agencies to address some of the factors that we've talked about that have led to some communities being disadvantaged and having a much larger impact due to COVID-19.
Is weight and height taken into consideration for COVID vaccine dosages administered? And why or why not?
I'll let Dr. Cohen or
Yeah, I saw that. I saw that no one jumped on that. The answer is no. There is no difference. I think it's a really good question, but the vaccine is just delivered into the muscle in the shoulder, and so presumably it doesn't matter how big the rest of your body is when you get the vaccine. We do know, though, that, for example, with hepatitis B vaccine, that one of the reasons that people don't get a good response to the hepatitis B vaccine is obesity. And so there may be issues and there may be ultimately tweaks, but right now it's one size fits all.
When will undocumented immigrants get vaccinated? Our local clinic requires a driver license.
Rachel, do you want to address that?
Sure. So, anyone can be vaccinated. You do not need documentation to be vaccinated, but you do have to be in the right, you have to have reached the eligibility, whether it's by age or by your occupation right now. So, I think if someone's having issues getting an appointment, they believe they're truly eligible, that's something that we would be happy to assist with. We don't want that to be a barrier. I think it's really easy to ask someone to show, and we have been asking people to be able to prove employment or age, because we are trying to be very careful and make sure we're getting the population that we're targeting. But we do understand that that can be challenging. And again, we don't want it to be a barrier. So I think if there is a concern there, if you're able to call public health, we can help.
Has the criteria for the red tier changed from the last time we were in red tier, or is it the same?
It's remained the same. In order for us to get to the red tier, we have to get to a level of below 7 per 100,000, and for case rate and positivity below 8%. One thing that may have changed is that before the guidance stated that we had to be in the red tier for 2 weeks before schools can open. That has been cut down to just 5 days. So we, in our communication with the schools and school officials, we're telling them that, especially as they're watching our numbers go down and trending down, and the fact that we've stated that hopefully in March that we will get to the red tier, is that they should be ready so that as soon as we get there and they're eligible to open, that they'll be able to jump on it.
What percentage of people do you think have been infected but were never tested?
I don't know if Dr. Cohen has an idea on that.
Yeah, I have some idea, but it's obviously just hopefully an educated guess. You know, our assumption is that between 40 and 50% of people who are infected don't have symptoms. And if you assume that the only people who are asymptomatic who are tested are people who are contacts of somebody else, there's probably at least another 30% of people above what we've found that are positive. That's a guess. So, for example, if there are 100,000 people described, it may be somewhere around 130 or 140,000 people really infected. That would be sort of an educated guess, but that's all it is.
With all the different variants appearing, should we expect that this will be an annual vaccine like the flu shot?
It will surely be a repeated vaccine. I don't know if it's going to end up being annual or not. I think we discussed this on one of the prior meetings. This virus doesn't mutate as fast as flu. It doesn't change as much. And I think part of the reason that we've been seeing so many variants pop up now is just because so many people have been infected. And when this becomes a seasonal virus, I think the numbers are not going to be that high. So the mutation rate is not going to be that high. So the number of variants popping up each season is not going to be like influenza. So I'm thinking that it may be more along the lines of 2, 3, or 4 years between vaccines. But there will be probably the need for annual vaccines unless the virus just disappears, which seems to be pretty unlikely.
If you live in a complex where someone had COVID-19, how do you get a contact tracer to come to your complex? Or how does contact tracing work?
So it could work in several ways. When a person gets a positive test, that test is reported to County Public Health, and we have a team that does the contact investigation and contact tracing. So part of that will be calling up the person with the positive test and then asking them about their contacts and then being able to call them. So if you have been at a place or in a room with someone who was positive, and when we called that person, they said, oh yeah, I was at my uncle's place and these were the people who were there, then that is one way that you will get notified. The other also is that if the person gets a positive test, they might just call you up and say, guess what? We went to that place on Sunday and I now have a positive test. I think you should get tested as well. So those are some of the ways in which you will be notified. Of course, if it's a large outbreak, then we might do a lot more outreach and we might even hear about it in the media if it gets out that this complex has a number of cases or that there's an outbreak that is being investigated. So that could be an additional way.
Earlier, there was some mentioning about adverse reactions with COVID-19 vaccines. And can a person become ill or die if they get a COVID-19 vaccine?
There is clearly the possibility. but it hasn't really happened. I think sometimes with these adverse effects, whenever one happens, that's sort of news. And because it's news, that tells you how rare that is. And you have to look at how many people have been vaccinated for every one of these severe cases. So yes, there are people who have allergic reactions that end up staying in the hospital overnight. That would be considered a severe reaction. There are people who have other effects that require hospitalization. I think there at least has been one report of a death after the vaccine. That said, I just point out how many people have died from COVID-19, and you have to look at the big picture and how many people have been vaccinated now and how rare these events are, right? You're not really even hearing about them anymore, right? It was at the beginning of the rollout, people were talking about, oh, this person got sick and this person got sick. Now everyone complains about the side effects, as Dr. Kasirye calls them, with the sore arm and feeling run down and things like that. But we're not really seeing people with really severe reactions. It's quite rare.
After the second dose of Pfizer or Moderna, how many months can an individual be protected?
That's an excellent question too. I just want to point out though, that this will evolve over time. So this is going to keep changing, because let's just say it this way. Those vaccine trials were done over the summer. The vaccines were approved in December. The studies ended in October. So what you're talking about is you can't tell whether somebody's been immune for much more than 5 or 6 months, because that's all the time that's passed so far. What we know from people who get natural COVID is that people can be immune at least 9 months. That's how far people have measured out. But the answer right now is we're not sure how long it's going to go. We know that it goes at least 5 months, and we'll sort of see as time rolls out. But that's what we can't answer, because we just don't have the time to follow people yet.
Another member says, I've heard that when one gets symptoms from the vaccine, you should not use any pain reliever other than Tylenol because it reduces the effectiveness of the vaccine. Is that true?
So there are studies in animals that suggest that using nonsteroidals may dampen the immune response. It doesn't prevent it, but it just, you get a little bit lower immune response. So what I tell my patients is, first of all, the vaccine makers already tell you don't take it before you get vaccinated. Second, I tell people if they have side effects that they should preferentially use acetaminophen, Tylenol. But if it doesn't control their symptoms, it's perfectly okay to take something like Advil or Naproxen or any of the non-steroidal drugs. So preferentially, I would say no, because at least there's this animal data, but we don't really have any information in humans. And I always say, might as well try to maximize the response that you're going to get.
And on that note, does vitamin supplements, can they reduce vaccine symptoms such as elderberry, vitamin C, zinc, etc.?
I'm not aware of any data. Is anybody else?
If the governor allows youth sports to proceed, will the county approve?
Yes, the county abides by the state guidance. And so if the governor does change the youth sports guidance, we will adjust our guidance as well.
When will teens age 13 and over be able to receive a COVID-19 vaccine?
Maybe Dr. Cohen knows that since he's more in tune with the studies.
I'm sorry, I've been trying to answer some of these questions in the chat. What was the question again, Mike?
No worries. When will teens age 13 and over be able to receive the COVID-19 vaccine?
So I can tell you that clinical trials have started already around the country for ages, I believe it's 12 to 18. Given the sort of the timeline of these studies and how long it takes to get everything done, my guess is that maybe by summertime.
On the note of children, another community member asked, in a childcare setting, if a parent requests that napping children wear masks, what is an appropriate response?
I'm sorry, what was the question again?
In a childcare setting, if parent requests that napping children wear masks, is that appropriate?
We do not recommend children that are sleeping or napping to wear masks because it could cause issues. And actually, children less than 2 years old should not be wearing masks to begin with.
Another community member asked, are the funds that were allocated to Sacramento County for COVID treatment being actively used?
I'm wondering which funds they're talking about. If it's the CARES funds, yes, we have been using the CARES funds for the COVID response. And we've used it for different things such as the contact tracing. And we have 11 sites in the community that we are supporting for testing for COVID as well. Our public health lab also does COVID testing. And we've been using that money also for getting ready for vaccination, COVID vaccines, like getting trailers that we can use out for vaccination, pop-up vaccination sites, as well as getting additional staff that will assist in the different areas. There's a lot of documentation that we're receiving in terms of faxes, and having additional staff to be able to do that was also important. A portion of that money was also used to go into the community for community-based agencies to assist individuals that were affected by COVID-19, either with additional food, help, financial help, or help with rent, and also with additional wraparound services. And I might add that we give a report at every board hearing about how we are spending that money, and also answer questions from the supervisors about the use of that money.
Is it true that younger people will likely have more severe side effects from the vaccine than older folks?
I don't know that that's necessarily the case. It does appear that within the healthcare workers where younger people are vaccinated, they may have a little bit more severe disease than old people like me. but I think that I wouldn't say that that's definitely going to be the case.
How is Sacramento County deciding where the vaccination centers are being placed?
I'll let Rachel start, and then I can add in as well.
Sure. So, initially we had to go, the state actually told us we can only give vaccine to providers that are in the state system. So initially it was just hospitals the first week or two. And after that, we brought in, clinic systems, urgent care systems, and some pharmacies. And so that's where we were using and reaching a very targeted population. Remember, healthcare workers, very specific group. And also really focusing on sites that could push through high numbers, because that's, it's important to everyone that we get this vaccine out, that it not be sitting in a freezer somewhere, that it really is being used every day, as many doses as we can. But we are looking at it. We do have a map, we map the sites, and we're looking at where the gaps are. It's very important to us to make sure that we're reaching into all those neighborhoods, especially as we open up more to the general public. But again, we're dealing with this same kind of number, the same allocation of vaccine. So those, I think we have great plans in place and partners in place that are ready and willing to go to those sites. And we really have to wait until we have enough vaccine, and still continuing to work through phase 1A and a lot of those workforce sectors. But it's definitely important. And we hope that when you look at our map, you'll continue to see that we're broadening out into those areas that appear that we've missed. And we haven't missed them. It's really just, there's a lot of factors at play. Again, like I said, the site has to go through an enrollment system with the state to be able to have the vaccine. And we have to be able to look and make sure it's safe. But we also have to have enough vaccine to get out to be given at those sites.
Yes, and in addition to that, just wanted to add that one of the things that we are working on is having a stakeholder group that will assist us with making some of those decisions about which sites we need to go to, and also building partnerships with the health systems as well as with the community-based agencies so that we can work together. We are putting together a plan that where we can have some of the health systems help us with staffing as well as with providing messages, and then working with the community-based agencies again as trusted messengers, and also being able to help with providing more access for people who have barriers, such as it could be a language barrier, it could be access to a computer, it could be transportation, or just being able to answer their questions. And so all of that takes time, and the plan keeps evolving and moving and developing. So, but I think the main message is that we do have a team that is looking at working with some of the disadvantaged communities to make sure that we get a vaccine to those areas as well.
Why are some healthcare workers not receiving the vaccines? Do they know something we don't?
I don't think so. So we have been putting together a work group actually to reach out to some of the healthcare workers that have not been vaccinated to try to get answers to why they're choosing not to be vaccinated. And I think one of the common things that we have found is that people think, well, I'm young, I'm not going to get very sick, even if I get COVID. And so I don't want to put myself at risk by getting the vaccine, even though I know the risk of the vaccine is very low. And I think we run a clinic at UC Davis, not my group, but another group of physicians run a clinic with patients who have what's called long COVID, where they are sick for months. And not all of them are 75 years of age, right? There are young people mixed into that group. And so I think we have to do some educating for people. We have healthcare workers who don't want to take flu vaccines just as well, right? Until we have county mandates, there have been a lot of healthcare workers that haven't taken flu vaccine. And so I think that people who are adverse or who don't like vaccines are present in all populations, whether they're healthcare workers or not, but they don't have any secret insights because the large majority of healthcare workers, I'd say almost 80% of the people that work at UC Davis have taken the vaccine.
Is there currently a wait list for vaccines?
Rachel, do you want to speak about
Sure.
that process?
Yeah, so we do have a survey on our website that people can take, so because that helps us to find them when we're ready to vaccinate their sector or tier when they're eligible. It's not necessarily, I mean, you could call it a wait list. For some people, it's not time, so that, you know, we are waiting. For some people, they're on a list and they are eligible, but we don't have enough doses, so we you know, we send invitations to clinics as we see openings. And so if that's the wait list you're talking about, yes, to some degree, there's a way to at least register. And with the My Turn website, I think you'll be able to register your age and your, you know, what your occupation is, and it's going to notify you when it's your turn to be vaccinated. So that, I think, is going to be hugely helpful when it's really up and off the ground.
Has there been discussions with the COVID-19 community testing sites transitioning over to become vaccine distribution sites?
Right from the start, we had talked about that possibility. And we just need to wait until we have more vaccine and are able to open up additional sites. We will, of course, have the discussion with the communities where those sites are to find out if those are still the best sites for us to have the vaccinations clinics, but we're also open to other sites as well.
There are, again, a few questions about eligibility and tiers and how to register for vaccines. So if we could take a moment, Liz, if you could pull up the COVID-19 vaccine website where folks could and share that. And then maybe we could have Rachel again go over before we conclude our event tonight on where we're at in terms of eligibility and the tiers.
You wanted me to do that now?
Yeah, or
Okay.
Liz?
Yeah.
Go ahead.
Get our diagram up, that'll help. While we're waiting, I'll just remind you that we started with phase 1A, and that is pretty much all healthcare workers and also persons who live in skilled nursing or assisted living facilities, and we're continuing to work on those populations. The federal government partnered with pharmacies to do the staff and the residents of assisted living and skilled nursing, but there's a lot of work, to continue there, and we'll continue doing that. So still vaccinating tiers 1, 2, and 3. So those are people that work in the healthcare field primarily. Clinics, nurses and doctors, dentists, people who work in lab, pharmacists, and those who do in-home care. It's a pretty broad group. It's a big group. And then we did open to phase 1B, and we're following state guidance as we open these groups. So when we open 1B, it doesn't mean we're done with 1A. It just means we understand the urgency and we want to continue to try to move forward while still capturing those we've missed. So 1B is opened up first to the 65 years and older, and then law enforcement and emergency services. And then this very week, we opened up to childcare and education. So we're not yet vaccinating those who work in food and agriculture. Again, waiting for some more vaccine to be able to make that next move. And then we'll continue, presumably on through these tiers, although the state has given us some indication there might be changes, and there have already been changes as we've been going. So we have to continue to consult with them for that guidance.
Thank you. And with that said, we would like to conclude our public health community forum. And again, we would like to thank all our wonderful panelists and speakers tonight. Before I close out, is there any other thing you would like to add or share with the community? Okay. Please stay tuned. And we'll see you in 2 weeks.